Tetralogy of Fallot, TOF. Definition: commonest form of cyanotic congenital heart disease. Consists of large perimembranous, non-restrictive, malaligned BSD. Results from anterior displacement of infundibular septum. Pulmonary stenosis, more commonly infundibular than valvular. Overriding of aorta and right ventricular hypertrophy. VSD defects usually infracrystal subaortic outlet type. Now, what associated defects with TOF? They are right-sided aortic arch 25%, persistent left superior vena cava 25%, abnormal origin of coronary arteries 5%, LAD originates from right coronary artery and passing over the RVOT alcapa. Complete AV canal defect 2%, more common with Down syndrome. MAPCA, rarely ASD secondum called Pentalogy of Fallot, and PDA. Now, hemodynamics of TOF. Direction of shunt depends on amount of obstruction at RVOT or at pulmonary valve level. If mild obstruction may be a bidirectional shunt with no cyanosis, that is acyanotic TOF, or even a left to right shunt. If severe obstruction, right to left shunt. Blood flow into aorta. Blood reaching the aorta has a reduced oxygen saturation as aorta receives full output of left ventricle and part of right ventricle. Blood into pulmonary circulation. Remainder RV blood reaches the lungs through an obstructed outflow tract, thereby having deficient circulation. Sometimes this circulation is improved by development of extensive aortopulmonary collaterals and bronchial arteries. Now, primary components of TOF, they are VSD and pulmonary stenosis. Secondary component of TOF, RBH and overriding of aorta. For Wadusar, pulmonary primary component of TOF are VSD, pulmonary stenosis and RBH. Now, development of TOF due to unequal separation of conus cordis. Presentation of TOF. Central cyanosis with digital clubbing. Effort intolerance. Breathlessness is associated with squatting, increases with exertion. Hypoxic attacks or cyanotic spells. Angina on effort. Extremely rare. Regarding cyanosis, 1/3 patients are cyanosed at birth. Many patients do not become cyanosed until end of first year. Both cyanosis and clubbing increases gradually with age due to increasing severity of pulmonary stenosis. 3/4 are cyanosed over the age of 2. Cyanosis develops after 6 months. Why? Due to sympathetic nervous system develops after 6 months of birth. TOF has sympathetic overactivity. Now, mechanism of effort intolerance. Exertion causes increased demand of tissues for oxygen. Due to increased right to left shunt, the amount of available oxygen decreases. Anaerobic muscle metabolism occurs with production of acid metabolites, that is acidosis. Stimulation of respiratory center, that is causes hyperventilation. Now, how dyspnea is relieved in TOF or benefits of squatting or knee chest position. Benefit from squatting position usually mainly due to decrease in the right to left shunt by raising the systemic vascular resistance by compression of the abdominal aorta and femoral arteries. Pressure on inferior vena cava trapping venous return in the legs, reduced venous return, reducing the amount of acid metabolites reaching the brain. Now, signs or findings of TOF. Precordium usually silent or cardiac impulse is quiet. No left parasternal lift, as there is infundibular pulmonary stenosis which lies just beneath the area of left sternal border. No palpable P2 due to small pulmonary artery. No thrill due to pulmonary hypoplasia. Second heart sound usually single. Ejection systolic murmur in pulmonary area, not long with severe pulmonary stenosis. Long if mild pulmonary stenosis with good flow. Murmur disappears during cyanotic spell. Continuous murmur if MAPCA or PDA present. So, continuous murmur if MAPCA or PDA present. Now, general examination of TOF. Suffused conjunctiva, central cyanosis, bilateral symmetrical claving. Pulse normal, maybe AF, asymmetrical due to BT shunt. Blood pressure low, JPP normal. Now, difference between isolated PS and PS in tetralogy of Fallot. Isolated PS has ejection systolic murmur with click. In PS in TOF, there is no ejection click. Right atrial gallop present in isolated PS, but there is no right atrial gallop in TOF. Left parasternal heap present in isolated PS, no left parasternal heap in TOF. Having systolic thrill in second intercostal space, no thrill due to pulmonary hypoplasia in TOF. Now, causes of asymmetrical pulse. The causes are Takayasu's arteritis, BT shunt, subclavian steal syndrome, aortic dissection, coarctation of aorta before subclavian artery. After subclavian artery coarctation causes radiofemoral delay. Now, what are the investigations in TOF? For diagnosis of TOF, we can do ECG, chest X-ray, PAVU, 2D M-mode and color Doppler echocardiography, cardiac catheterization. For treatment purpose, we can do CVC to evaluate anemia and polycythemia, packed cell volume to take decision regarding phlebotomy, serum iron profile and peripheral blood film to evaluate relative anemia when anemia clinically absent, hemoglobin normal, serum uric acid. Other investigations are CT angiogram and MRI. Now, what are the findings in ECG? There may be RVH, right axis deviation, RVH with strain, inverted T waves. If RV pressure increases systemic pressure, RA enlargement, P pulmonary in adult TOF. Left axis deviation if AB canal defect. Left axis deviation if AB canal defect. Never RBB. There is never RBB in TOF. There is no right abundant branch block in TOF. Why boot shape in TOF? Due to concave pulmonary way and upturned apex. Why upturned apex? Because absent or hypoplastic. Why concave pulmonary way? Because absent hypoplastic main pulmonary artery. Horizontal IVS producing straight upper portion. Horizontal IVS producing straight upper portion, convex or rounded inferolateral portion of LV apex. Findings in chest X-ray. Classic core and sabot, boot-shaped heart or clock-shaped due to combination of right ventricular hypertrophy lifting the apex of left heart. Pulmonary base usually deep due to hypoplastic pulmonary artery. If pulmonary valvular stenosis, pulmonary trunk prominent, oligemic lung field. Others, unilateral rib notching if collateral intercostal arteries. Aortic knuckle above right atrium if right aortic arch. Now, findings in echo. Parasternal long axis view shows VSD overriding of aorta, that is less than 50%. Aortomitral continuity present. Aortoseptal discontinuity present. Dilated coronary sinus if persistent left superior vena cava. Parasternal short axis view shows VSD, that is perimembranous, subaortic or infracrystal, that is in 10 o'clock position. RVOT obstruction and gradient, any PDA can be seen. Apical 4-chamber view shows VSD type, VSD pressure gradient. Suprasternal view for right-sided aortic arch. Now cardiac catheterization or findings. Hemodynamic findings, systemic desaturation, trajectory, 2C persistent left superior vena cava, RB graphy, RB OT, infundibular pulmonary valvular stenosis, branch pulmonary artery stenosis, LB graphy for BSD. Root aortogram, abnormal origin of coronary artery, arch aortogram in any right-sided aortic arch, descending thoracic aortogram to C MAPCA, descending thoracic aortogram to C MAPCA. Role of cardiac catheterization in TOF, to confirm the diagnosis of TOF, to determine the number, location, size of VSD and its relation with the great arteries, to know the associated anomalies such as sideness of aortic arch and its branches. Right-sided aortic arch is present in 25% cases. Any aortopulmonary collaterals. To delineate anatomy of RB outflow tract and branch pulmonary artery stenosis. To find out the coronary artery anatomy, especially origin of LAD and its courses. Now, what are the complications of TOF? There is cyanotic spell, cerebral abscess, cerebrovascular accident, subacute infective endocarditis, congestive heart failure, iron deficiency anemia, hyperviscosity syndrome, and gout. How cerebral abscess occurs in TOF? By paradoxical embolism. Venous clot originates from deep veins of leg entering deep left leg or mesentery, entering the systemic circulation through septal defect. How anemia occurs in TOF? Due to reduction in RBC deformability together with a reduced oxygen delivery, due to infection and malnutrition. So, how anemia occurs in TOF? Due to reduction in RBC deformability together with a reduced oxygen delivery, due to infection and malnutrition. When congestive heart failure develops in TOF, in restrictive VSD called Hoffman's variant, infective endocarditis in tricuspid valve causing TR, significant iron deficiency anemia, aortic regurgitation, regurgitant jet to RV due to overriding of aorta, RV dysfunction in long-standing cases with systemic hypertension. Now, management of TOF. There are general management. Avoid dehydration, plenty of fluid to prevent hyperviscosity. Treatment of infection, correction of anemia, prophylaxis for infective endocarditis. Management of cyanotic spell. Child is placed in knee chest position to reduce right to left shunt. Oxygen is given preferably in a tent. Morphine 1 microgram per kg IV or 0.2 microgram per kg IV to relax the infundibular tone, thereby reduce right to left shunt. So, we will give morphine IV. The dose is 1 microgram per kg or 0.2 microgram per kg to relax the infundibular tone, thereby reduce the right to left shunt. Propanolol 1 to 3 milligram per kg per day orally. 1 to 3 milligram per kg per day orally. Due to its anti-inotropic effect, relax RVOT, reduce or prevent further attacks. Sodibicarb IV if acidosis presents. Adequate hydration. Convulsions or epileptic fits. Treated with IV phenytoin or phenobarbital. In cases of convulsion or epileptic fits, we will treat with IV phenytoin or phenobarbital. So the options of management of cyanotic spell are: child is positioned in knee chest position, oxygen is given, morphine is given in IV, propanolol orally, sodibicarb if acidosis, adequate hydration, convulsion or epileptic fits, we can give IV phenytoin or phenobarbital. Now, what are the surgical management for TOF? We will do palliative surgery and definitive or corrective surgery. For what are the indication for palliative surgery? Very small infants less than 5 kg weight with recurrent spells. Pulmonary artery anatomy unsuitable for corrective surgery. Small pulmonary artery that is less than 1/3 of aortic size. What is small pulmonary artery? If it is less than 1/3 of aortic size. TOF with pulmonary atresia. Unfavorable coronary artery anatomy. In these cases, we can do palliative surgery. Now, total correction. Glutaldehyde treated. Total correction, that is total correction. Closure of VSD. Closure of VSD by glutaldehyde treated pericardial patch or PTFE patch. What are the total correction about TOF? Total correction are: closure of VSD, infundibular resection with or without, infundibular resection with or without, the placement of a transannular patch across the pulmonary annulus. In more extensive or more severe RVOT stenosis, coronary artery anomalies, complete bypass of the RVOT by placement of a valve conduit. So, we can give valve conduit in more extensive, more severe RVOT stenosis and coronary or coronary artery anomalies. Now, palliative surgery options. What are the options for palliative surgeries? Surgical palliation consists of systemic arterial to pulmonary arterial shunts. So, surgical palliation consists of systemic arterial to pulmonary arterial shunts to increase blood flow to the pulmonary arteries. They are classic VT shunt, Blalock toxic shunt. So, they are classic VT shunt where direct anastomosis between subclavian artery and ipsilateral pulmonary artery. Now, not done nowadays, currently by historical interest. Modified VT shunt. In this case, anastomosis between subclavian artery and ipsilateral pulmonary artery with placement of a tubular Gore-Tex tube. So, modified VT shunt is done by anastomosis between subclavian artery and ipsilateral pulmonary artery with placement of a tubular Gore-Tex tube. Other shunts are Waterstone shunt, Potts shunt, Glenn shunt. So, the name of other shunt are Waterstone shunt, Potts shunt, and Glenn shunt. What is Waterstone shunt? Ascending aorta to right pulmonary artery. Potts shunt, descending aorta to left pulmonary artery. Glenn shunt, superior vena cava to ipsilateral pulmonary artery. Now, timing of surgery. For palliative surgery done as an emergency basis, corrective surgery as early as 3 to 4 months of age to first or second year of life. Now, what are the complications of total correction? Pulmonary regurgitation, mild, may occur. RBBB in 90% of patients caused by right ventriculotomy is well tolerated. So RBBU occurs in 90% of patients. It is caused by right ventriculotomy, is well tolerated. AB block. Complete heart block occurs less than 1% cases due to damage to conduction system at or below bundle of his during VSD closure. Needs permanent dual chamber pacemaker. Ventricular arrhythmia. Ventricular arrhythmia occurs due to severe pulmonary regurgitation, RV dilatation, tricuspid regurgitation. Originates from region of transannular patch, ventriculotomy, suture lines. RB2 pulmonary artery valved conduit, progressive stenosis. Now, natural history of TOF determined by the severity of obstruction to RB outflow tract. So, natural history of TOF determined by the severity of obstruction to RB outflow tract. A total of 66% unoperated patients live to age 1 year. 66% of unoperated patients live to age 1 year. 49% patients live to age 3 years. 24% patients 10 years. Only 3% patients reach 40 years of age. Chance of survival greatly diminished when complete pulmonary atresia present. So, chance of survival greatly diminished when complete pulmonary atresia present. A cyanotic patient becomes cyanotic over time. Complications of right to left shunting. Complications of right to left shunting across small non-restrictive VSD causes cyanosis, erythrocytosis, thrombocytopenia, increased risk of paradoxical emboli, cerebral abscess formation. Patients are at high risk for developing infective endocarditis. Malignant ventricular arrhythmia and congestive heart failure are major cause of death. Cause of death. The causes of death are cyanotic spell, commonest mode of death in infancy and childhood. Malignant ventricular arrhythmia and congestive heart failure, major cause of death in adults. Cerebral abscess and infective endocarditis. Thank you.